This is the nervous system lecture, part 2 continued. Now, when we talk about the central nervous system, as you recall from the previous lecture, the central nervous system involves two major structures. That would be the brain and the central nervous system. Would be the brain and the spinal cord. Now, as you can see, caudally to the central nervous system, you'll see that the areas of the spinal cord begin with the cervical region and then extend down to the thoracic region, the lumbar region, and then the sacral area. From each of those areas, you'll see spinal nerves actually come off of the spinal cord at each level, beginning at the base of the brain, extending down again through the cervical region, spinal nerves also coming down the thoracic region, spinal nerves also exiting the spinal cord in the lumbar and the sacral region. And it's these areas and the anatomical structures involved here that we'll talk about here over the next hour. Now, the superficial anatomy and orientation of the adult spinal cord is as per that illustration that I showed you earlier. The numbers on the left side identify the spinal nerves, which indicates the nerve root where it leaves the vertebral canal. The spinal cord, however, extends down from the brain only to the vertebral level of about the lumbar level 1. The spinal segments are found there, representative location, are indicated in that cross-sectional illustration that I showed you earlier. Now, what are some of the other makeups of the spinal cord? Again, you've seen the spinal nerves as they exit from the spinal cord. They're made up of a ventral root nerve and a dorsal root portion of the nerve as well, and I'll go into more detail about those in just a minute. It will be important for you to identify which area of the spinal cord would be referred to as the ventral area, and which area of the spinal cord would be indicated by the dorsal area. You can tell this by looking at the vertebral column itself and the vertebrae, each individual vertebrae. If you recall from A&P 1, each vertebrae has a spinous process. The spinous process is representative of the posterior aspect of the cord, or where the dorsal root would be exiting. So it's important to be able to identify that area. So always identify the region, the regional anatomy, when you're trying to identify which segment of the spinal cord we're referring to. There's an important difference between what occurs in the ventral root nerve and the dorsal root nerve, and we'll go into more detail about that in a bit. Also, pay attention to the coverings of the spinal cord. These same coverings will extend around the brain. The coverings I refer to are the pia mater, the arachnoid mater, and then the dura mater. These are coverings, or meningeal layers that cover the central nervous system. Here we're looking at the spinal cord, so those meningeal layers actually cover the spinal cord, but remember, they extend up and also cover the brain itself. Now, the layers are arranged starting at the most deepest layer, or the layer that is closest to the nervous system tissue itself. That would be the pia mater. It is intimately connected to the spinal cord. The layer just above the pia mater would be the arachnoid mater, and the outermost layer would be the dura mater. Now, there are little spaces between each of these layers. Between the pia mater and the arachnoid mater is a space referred to as the subarachnoid space, and between the dura mater and the arachnoid mater is an area or a space referred to as the subdural space. Now, above the dura mater, but between the brain case itself, or the skull, is also a space. That space is referred to as the epidural space. And I'll go into more detail about each of these areas in just a bit. You're looking at a sectional view, and you're looking from a superior location down onto the spinal cord. And again, you can see this being the posterior area. You know that because of the spinous process, which means that this area is going to be representative of the dorsal root. This would be the anterior region, so it's going to be representative of the ventral root, or the ventral root nerve is going to exit from this point. Other areas that are important to note, again, here is the pia mater. The pia mater, again, intimately connected to the spinal cord itself. Again, I told you I was going to point out certain spaces that were here between each of those meningeal coverings. Here's the pia mater. Again, it lies closest to the nervous system tissue. There's a space between the pia mater and this other layer referred to as the arachnoid mater. That's referred to as the subarachnoid space. Here's the outermost layer, the dura mater, and there's a space that lies here as well, referred to as the subdural space. Again, exiting off the cord, you see dorsal root ganglion, consistent with the posterior aspect of the cord, and ventral root ganglion, consistent with the anterior portion of the cord. Now, these two divisions, or these two nerve roots that come off, form the spinal nerve, and you'll see there's a dorsal ramus and a ventral ramus, which will supply innervation for both sensory and for motor innervation. The posterior view of the spinal cord shows the meningeal layers, again, as I've identified for you. Now, there is also distribution of fibers referred to as gray matter and white matter. The gray matter, remember, is unmyelinated nerve tissue. White matter refers to myelinated nerve tissue. Now, the dorsal root ganglion. Every spinal segment is associated with a pair of dorsal root ganglion. They are situated near the spinal cord. These ganglia contain cell bodies of sensory neurons. The axons of the neurons form the dorsal roots, which bring sensory information into the spinal cord. The dorsal root ganglion lies between the pedicles of the adjacent vertebrae. Please refer back to the illustration to see exactly what I mean anatomically. A pair of ventral root contains axons of motor neurons that extend into the periphery to control somatic and visceral effectors. Remember, somatic effectors would go to muscles that we have direct control over, conscious control over, whereas visceral effectors would go to areas of muscle where we do not have conscious control over. The GI tract, the muscles that are innervated, that are inside blood vessels, those we don't have conscious control over. Somatic muscles would refer to skeletal muscles that we have conscious control over. On both sides, the dorsal and the ventral roots of each segment pass between the vertebral canal and the periphery at the intervertebral foramen between successive vertebrae. Again, if you don't remember where the intervertebral foramen is located at, please go back to the skeletal system from A&P 1 and review that foramen. Remember, foramen are small holes where nerves and blood vessels will pass through. In this particular case, we're talking about a nerve passing through. Distal to each dorsal root ganglion, the sensory and the motor roots are bound together by a single spinal nerve. Spinal nerves are classified as mixed nerves, which means they contain both afferent sensory and efferent motor fibers. Now, from the spinal cord, there are 31 pairs of spinal nerves. Each are identified and associated with the adjacent vertebrae. I'll give you an example. When we talk about cervical spinal nerves, even cervical nerves, we make this statement because these nerves exit in close relationship to the cervical vertebrae that are next to these spinal nerves. Now, when we indicate a specific spinal nerve, it is customary that we give a regional number. Each spinal nerve typically is inferior to the first thoracic vertebrae, and it takes its name from the vertebrae that's immediately preceding that. Now, the spinal nerves that emerge immediately inferior to the vertebrae of the spinal nerve follows the vertebrae, and this sequence follows all the way down to the inferior aspect or the caudal region of the spinal cord. Now, the arrangement differs in the cervical region because the first pair of spinal nerves actually passes between the skull and the first cervical vertebrae. And if you recall from A&P 1, the first cervical vertebrae is the atlas. So for this reason, the cervical nerves take the name of the vertebrae that's immediately following it. Now, this is unlike you'll see in the thoracic region, the lumbar, and the sacral region. So for the cervical region alone, the arrangement is different because the first nerve that actually exits below the skull. So it's between the skull and the first cervical vertebrae. That's C1. And so the cervical nerve, C1, takes its name from the vertebrae that's actually below it. Now, the cervical nerves proceed down the vertebral column. The same system is used for the rest of the cervical nerves in that series. A transition will take place in the numbering system once the last nerve passes under the last cervical vertebrae. At this point, the sequence of nerves will change, and the first thoracic vertebrae, the nerve that passes under that, will be T1. So the spinal nerves found at that location has been designated, and therefore, although there are only 7 cervical vertebrae, there are 8 cervical nerves. The spinal cord continues to enlarge and elongate until individuals reach approximately the age of 4. Up until that time, enlargement of the spinal cord keeps pace with the growth of the vertebral column. Throughout this period, the ventral and dorsal roots are usually very short. They enter the intervertebral foramina immediately adjacent to the spinal segment. After about the age of 4, the vertebral column continues to elongate, but the spinal cord does not. Let me emphasize that. That's up until about the age of 4. The vertebral column itself, that's the bony part in the canal, will elongate, continue to elongate after the age of 4, but the spinal cord itself stops elongating after about the age of 4. Now, the vertebral growth moves the intervertebral foramina, and thus the spinal nerves will be farther from their origin and position relative to the spinal cord. So because the column itself is going to continue to grow and the spinal cord will not, you'll see most of the spinal nerves come out and go down in relationship to the spinal column. Also, because the spinal column continues to grow and the cord does not, typically at about the level of L1 or L2, there is a space between in the lumbar region of the vertebral column. There's a gap because the cord stops at about L1, L2, but the column continues to extend, so there's a space usually in the thoracic area that does not have cord. Now, it does have the nerve fibers that will extend down from the inferior portion of the spinal cord, but there's no true spinal cord below L1 or L2. The dorsal and ventral roots gradually elongate. Correspondence between the spinal segment and the vertebral segment is usually lost. In adults, the sacral segment of the spinal cord are at the level of the vertebrae, so it differs when you get down to that region. Because the adult spinal cord extends only to the level of about the first or second lumbar vertebrae, the dorsal and ventral roots of the spinal segment to extend inferiorly, past the inferior tip of what's referred to as the conus medullaris, or the most inferior portion of the cord. When seen in gross section, you'll see an area referred to as the filum terminale. These are long ventral and dorsal roots that resemble a horse's tail. As a result, early anatomists call this complex the cauda equina. Now, basically, these are the spinal nerves that are coming from the most inferior aspect or the most caudal aspect of the spinal cord. Those nerve roots will extend down, and because of the way they extend down, it gives the appearance of the hairs of a horse's tail, and thus the name cauda equina. Now, the covering of the spinal cord and the covering of the brain. This is referred to as spinal meninges. The vertebral column and the surrounding ligaments, tendons, and muscles isolate the spinal cord from the external environment. The delicate neural tissue must also be protected from damaging contact with the surrounding bony walls of the vertebral canal. The spinal meninges, which is a series of specialized membranes surrounding the spinal cord, provide the necessary physical stability and shock absorption. Blood vessels branching within these layers deliver oxygen and nutrients to the spinal cord. The spinal meninges consist of 3 layers: the dura mater, the arachnoid mater, and the pia mater. Now remember, I showed you on the earlier illustration that the pia mater is most intimately connected to the spinal cord itself. It is the deepest layer. Above the pia mater is the arachnoid mater, and above the arachnoid mater is the dura mater. There are spaces, a space between the arachnoid mater and the pia mater. That space is the subarachnoid space. A space between the dura mater and the arachnoid mater, referred to as the subdural space. Above the dura mater is a space between the dura mater and the skull itself. That is referred to as the epidural space. At the foramen magnum of the skull, the spinal meninges are continuous with the cranial meninges which surround the brain. The layering remains the same. There is a condition referred to as meningitis. This is a bacterial or viral infection that can cause inflammation in the meningeal membranes. Meningitis is very dangerous because it can disrupt the normal circulatory pattern of cerebral spinal fluid and blood flow. It damages and even kills neurons and the neuroglia in the affected area. Now, although an initial diagnosis may be specific about the meninges of the spinal cord, spinal meningitis or cerebral meningitis in its later stages, the entire meningeal system usually becomes affected. Even if the initial insult is to a specific area, because of the flow of the cerebral spinal fluid, typically all of the meninges will become inflamed. Now, that outermost layer, as I described before, was referred to as the dura mater. This is a tough, fibrous layer. It forms the outermost covering of the spinal cord. This layer contains dense collagen fibers that are oriented along the longitudinal axis of the cord. Between the dura mater and the walls of the vertebral canal lies the epidural space. This is a region that contains loose connective tissue, blood vessels, and protective padding of adipose tissue. Now, there is a procedure referred to as an epidural block. You may have also heard of a procedure referred to as an epidural steroid injection. Epidural blocks, anesthetics, are medicines that typically cause a decrease in motor and sensory innervation. Anesthetics are often injected into the epidural space. And remember what I said, the epidural area is that area between the dura and the skull itself. There is a space. In that space is a fluid medium. Now, when anesthetics are introduced this way, the drug will usually affect only the spinal nerves immediately in the area of injection. In other words, if I enter into the epidural space of L1, the nerves immediately around L1, which may mean T12, L1 itself, and L2, typically sensory loss, motor paralysis, typically is seen depending on the anesthetic that is selected. Epidural blocks in the inferior lumbar area or sacral area may also be used to control pain and may also be used to control pain during childbirth. Thus, epidural steroid injections can be used targeting an anesthetic and a steroid medicine which decreases inflammation to control back pain, or in a larger volume of anesthetic can be used to control pain during childbirth. The other layer, the arachnoid layer, the arachnoid mater. In the most anatomical and histological preparation, a narrow subdural space separates the dura mater from the deeper meningeal layer, the arachnoid mater. It is likely, however, that in life no such space exists and that the inner surface of the dura mater is actually in contact with the outer surface of the arachnoid. The arachnoid being the middle meningeal layer. Now, the subarachnoid space, the inner surface of the dura mater and the outer surface of the arachnoid, are covered by a simple squamous epithelium. The arachnoid includes epithelium called the arachnoid membrane, the arachnoid trabeculae, which is a delicate collagen and elastic fiber that extends between the arachnoid membrane and the outer surface of the pia mater. Now remember, we're talking about the subarachnoid space, which means it has to be below the arachnoid layer, which is the middle layer, and the next layer, closest to the spinal cord itself, would be the pia mater. So the space is between the arachnoid mater and the pia mater. The intervening region referred to as the subarachnoid space. Now, this area is typically filled with cerebral spinal fluid. This is important, so I'm going to say it again. The subarachnoid space is typically filled with cerebral spinal fluid, which acts as a shock absorber and a diffusion medium for dissolved gases, nutrients, chemical messengers, and waste products. The spinal arachnoid extends inferiorly as far as the filum terminale, and the dorsal and the ventral roots of the cauda equina lie within the fluid-filled subarachnoid space. In adults, withdrawal of cerebral spinal fluid in a procedure known as a spinal tap, also known as a lumbar puncture, involves the insertion of a needle into the subarachnoid space in the inferior lumbar region. This placement of a needle avoids damage to the spinal cord. Spinal taps are usually performed when the central nervous system infection is usually suspected, or to diagnose conditions such as severe back pain, headaches, disc problems. Some types of strokes can be identified this way, strokes that involve bleeding, subarachnoid hemorrhages, for example. Also may be used to diagnose certain types of tumors or cancers, cancers that invade the spinal cord, or even cancers that involve the central nervous system itself. Now, once cerebral spinal fluid is withdrawn from this space, samples are usually sent for analysis. Now, these samples typically are just of the cerebral spinal fluid. There's actually no sample of neural tissue. This is not a biopsy per se, but these fluids are usually sent to the lab, and just as we analyze blood for glucose levels, electrolyte levels, the cerebral spinal fluid has these same constituents in it. Now, cerebral spinal fluid is typically clear as water. The volume of cerebral spinal fluid that's collected usually ranges between 3 to 12 cc's. Cerebral spinal fluid intimately is associated with neural tissue, so any pathogens, cell debris, metabolic waste in the CNS usually can be detected in the cerebral spinal fluid. Bacterial cultures are typically done from this in people who are expected to have meningitis. The spinal fluid should be clear, so any type of cellular debris would be considered to be abnormal. Now, the withdrawal of cerebral spinal fluid, the spinal tap itself, must be done with care because you don't want to injure the spinal cord, which is in close proximity to where the lumbar puncture is going to take place. Now remember, the adult spinal cord extends inferiorly only as far as L1, L2. Now, after L1, L2, remember the cauda equina, or the dorsal and ventral root nerve roots, will come off the spinal cord. They actually will extend it down into that space or that gap between L1 and the sacral area. But these are like hair-like structures. And so actually when you insert a needle into the subarachnoid space, these little nerve fibers usually just move right out of the way of the needle. So it would be extremely rare, if not almost impossible, to injure those little roots from the cauda equina. There's a gap between L1 and the sacral vertebrae. So this is a great place to do the lumbar puncture. Now, again, there is fluid there, cerebral spinal fluid, and so by inserting the needle into that area, the fluid typically is easily obtained. Now, when a spinal tap is being performed, the vertebral column is usually flexed. And what do I mean by flexed? Anteriorly, the spinal cord is flexed, so the person typically would be placed in a fetal position. Now, the person can be side-lying, or the person can be sitting in an upright position, but asked to lean forward, as if almost lean and hold on to their knees. This flexes the spinal cord, or should I say, it flexes the vertebral column, and actually allows a small gap to be formed between each of the vertebrae. The needle is then inserted inferior to a lumbar vertebrae into the subarachnoid space. There is minimal risk again to damaging any of the nerve roots of the cauda equina. The risks are low primarily because the volume of CSF is much greater than the volume of neural tissue in that area. The needle is inserted with a plug. In other words, this needle that's inserted is not a hollow needle. It actually has a plug or a stylet through the opening or through the bevel of the needle. And as the needle is passed through the bone, as the needle is passed between the vertebrae of the lumbar region and into that space, then the center of that needle or that core is removed. So the center of the needle has something referred to as a stylet, which fills up that space. If this wasn't the case when the needle was inserted through the skin and between the vertebrae, a core of tissue would fill up the needle. To avoid this, a stylet, or something that plugs the needle, is in position in the needle as it's inserted into that space. Now, once the needle is felt to be in the subarachnoid space between L2 and the first sacral vertebrae, then that stylet is removed. When the stylet is removed, typically the spinal fluid will begin to drain out by simple gravity, just as you would tap a maple from a tree. Primary purpose of the plug, again, or the stylet, is to prevent the introduction of superficial tissue into the cerebral spinal fluid. And the stylet is withdrawn after the insertion of the needle. Now, the procedure, the lumbar puncture, again, it usually takes 3 to 9 milliliters or cc's of fluid. That can vary. Some cases you take a little bit more. In some cases, if you only get 2 cc's or 3 cc's of fluid, then you will take that specimen as well. Here's a cross-sectional view of the vertebral column. And remember, these vertebrae are flexed. So the spinal column itself is going to be anterior flexed, and the space between each of these vertebrae will be opened up, and the needle would be inserted between these vertebrae. Needle can easily pass through this cartilaginous structure into this space, and notice how much area is here. So the bevel of the needle can easily fit into this region without damaging any neural tissue. Now, here are some of the little nerve roots from the cauda equina. And remember, these are free floating in this fluid, and typically these little nerve roots just float out of the way and the needle does not damage them. The lumbar puncture needle is in the subarachnoid space between the nerves of the cauda equina. The needle has been inserted between the third and fourth spinous process. That's an excellent place to make the puncture site, because remember, the spinal cord stops at about L1, so certainly at the lumbar 3 and 4 area there should be no spinal cord. Now, in this space, sometimes a radiopaque dye can also be injected into the area and help the neural tissue be able to show up better on an x-ray. This procedure is referred to as a myelogram. An x-ray image of the spinal cord after a radiopaque dye has been introduced into the central spinal fluid, the cerebral spinal fluid of the inferior lumbar region. And again, this is an image that would be taken from a myelogram. And you can see by injecting this radiopaque dye, you can now see tissue of the spinal cord. A regular x-ray typically won't show tissue. It shows bone really well, but it won't show tissue. The only way to show the tissue is to actually inject a radiopaque dye. The fluid from cerebral spinal fluid or from a spinal tap is withdrawn by gravity only. It is not drawn by suction. If you actually applied suction to the needle, you could potentially pull one of the nerve roots against the tip of the needle, and that would indeed injure them. So the fluid drips out under its own pressure. The process resembles the collection of maple syrup from a maple tree, as I alluded to earlier. Now remember, it drips under pressure. Gravity is a role, but inside the spinal canal there is pressure. That pressure is created by the structures in the central nervous system, the brain and the spinal cord, and the fluid that is there. So there is a degree of pressure, and by placing a needle, the pressure is going to go through the path of least resistance, which would be through a hollow needle. Spinal taps are performed when the central nervous system infection are suspected, severe back pain, headaches, disc problems, some types of strokes, and again, as I alluded to earlier, some cancers can also be diagnosed from this method as well. Many demyelinating diseases, such as multiple sclerosis, Guillain-Barré syndrome, can also be diagnosed from this as well. Forms of multiple myeloma can also be diagnosed from spinal taps. The myelography, as I've already explained to you earlier, is just basically the introduction of radiopaque dye into the cerebral spinal fluid in the subarachnoid space. Because dyes are opaque to x-rays, the CSF appears white on the x-ray image. Any tumors, inflammation, adhesions, distortions in the spinal cord itself can be seen based upon this CSF circulation. Spinal taps and myelography allow diagnosis of severe infections, inflammation, or leukemias, which are basically cancers of the white blood cells. Treatment may then involve injecting antibiotics, steroids, or anti-cancer drugs into the subarachnoid space. The next layer, the layer that is most intimately connected to the central nervous system tissue, is the pia mater. And in this gross slide that's before you now, you can see the up-close appearance of the spinal cord itself. Note the spinal nerves as they exit at each particular level. Please note that the pia mater, again, cannot be easily separated from the tissue itself. Now, the other layers can. The arachnoid mater, as you can see, is separated out here. And again, above the arachnoid mater would be the dura mater. You can also see ligaments that I referred to earlier, denticulate ligaments, which I will describe in more detail in just a bit. There are also blood vessels, spinal blood vessels that run along the median aspect of the spinal cord. In the cervical spinal cord, and the picture that you looked at earlier is an anterior view of the spinal cord and the spinal root nerves as they come off the vertebral column. The dura mater and the arachnoid mater have been cut and they've been dissected away. You'll see blood vessels again that run along the subarachnoid space bound to the outer surface of the pia mater. The subarachnoid space bridges the gap between the arachnoid epithelium and the innermost meningeal layer, the pia mater. Now, the pia mater consists of a meshwork of elastic and collagen fibers that are firmly bound to the underlying neural tissue. These connective tissue fibers are extensively interwoven through the span of the subarachnoid space and firmly binding the arachnoid to the pia mater. The blood vessels servicing the spinal cord run along the surface of the spinal pia mater within the subarachnoid space. The denticulate ligaments along the length of the spinal cord, paired denticulate ligaments, extend from the pia mater through the arachnoid to the dura. The denticulate ligaments, which originate along either side of the spinal cord, prevent lateral, side-to-side movement of the cord. The dura connection at the foramen magnum and the coccygeal ligaments prevent longitudinal, superior to inferior movement. Now, this is important, and I'll emphasize this again. Those denticulate ligaments prevent the side-to-side or the lateral movement of the spinal cord. This helps to prevent injury. Longitudinally, there are ligamentous connections between the dura connection at the foramen magnum and the coccygeal ligament, and this prevents superior to inferior movement of the cord. I suppose this is why we're able to bungee jump without disrupting our brain and our spinal cord. Now, the spinal meninges accompany dorsal and ventral roots as these roots pass through the intervertebral foramina. The meningeal membranes are continuous with the connective tissue that surrounds the spinal nerves and the peripheral branches. Now, let's look at the anatomy of the spinal cord itself again, so you know regionally where certain structures are located at. Remember before I told you it will be important for you to appreciate and understand where the posterior aspect of the cord is located at and where the anterior aspect of the cord is located at. This is important because the ventral root of the nerve is going to exit anteriorly. The dorsal root is going to exit posteriorly. Now, in the previous slides that I've shown you, you had the spinal process as a guidepost to identify which area of the cord you were looking at. In this illustration, there is no vertebrae, so you don't have a spinous process. So you're actually looking at a cross-section of just the spinal cord. Now note two structures that will be very helpful for you to identify what the dorsal root and where the ventral root is. If you look at the cord itself, it kind of gives you the impression of a butterfly. The larger wing of the butterfly is usually in a more anterior position. Another thing that can help you to identify the this structure is the anterior median fissure. Note that the anterior median fissure is much larger than the posterior inferior fissure that you'll see here. It's referred to as the posterior median sulcus. Important to note that the fissure has a gap, has a space. The sulcus is mainly a groove. This helps you to determine which portion of the cord is anterior and posterior. Once you know this is the anterior portion of the cord, you know that this area would be related to the ventral root. Ventral root has specific innervation to motor innervation, whereas the dorsal root has specific innervation for sensory. So knowing that, you can now determine which area of the cord is related to somatic motor, which would be the most anterior region. More medially, but yet anterior, would be the visceral motor. Remember, somatic motor controls skeletal muscle. It's those muscles that we have conscious control over, so the nervous system can move those muscles consciously on a conscious level. The visceral motor roots typically only affect visceral motor structures, such as the gastrointestinal muscles, where we have no conscious control. The muscles that have blood vessels, which again dilate and constrict blood vessels, we don't have conscious control over that. Similarly, if we approach it from the posterior view, this is going to be the dorsal root. And dorsal root has sensory innervation. Again, most posterior is going to be the somatic sensory root. The somatic sensory root, again, senses those structures that we have conscious control. So sensory innervation from the tips of our fingers that allow us to feel something and react to the environment. Those sensories typically send information to the motor roots that we have conscious control over. There are also visceral sensory roots that will innervate structures that we don't have conscious control over, that work automatically or on their own. Those again, GI tract, blood vessels, so forth and so on. Visceral sensory. So it's important to understand each of these areas graphically seen here. The posterior horn thus will have sensory roots from sensory motor, and from somatic motor and from visceral motor. The lateral horn, typically the median structures here of the lateral horn are usually going to involve visceral fibers of both sensory and motor, and then the anterior gray horn, usually somatic motor of the ventral root. This is it in a gross histological slide. This segment of the cord has been stained and prepared on a slide, as you can see here. And again, the pattern is going to be the same. Notice how the larger wing of the butterfly is going to be lying in a more anterior position. You can easily see the anterior median fissure, so you know these are going to be ventral root structures. Posteriorly, again, there is the posterior median sulcus that you can identify. Again, not a gapping fissure like we see anteriorly, but more of a groove. And again, you know these are going to be posterior roots or dorsal roots. And again, we're going to have more to do with the sensory aspect of nervous system innervation. Now, the cell bodies of neurons in the gray matter of the spinal cord are organized into functional groups called nuclei. Sensory nuclei relay sensory information from the peripheral receptors. That makes sense. Sensors have to receive information from peripheral structures. The motor nuclei issue motor commands to the peripheral effectors. This makes sense as well. Commands come from the central nervous system and go out to peripheral motor structures. Although sensory and motor nuclei appear rather small in the transverse section, they may extend for considerable distances along the length of the spinal cord. Frontal sections along the length of the central canal of the spinal cord separate sensory, posterior, and or dorsal is the term that refers to those nuclei, from the motor, which is referred to as anterior or ventral nuclei. The posterior gray horn contains somatic, visceral sensory nuclei, whereas the anterior gray horn contains somatic motor nuclei. Lateral gray horns located in the thoracic and lumbar region contain visceral motor nuclei. The gray commissures posterior to and anterior to the central canal contains axons that cross from one side of the cord to the other before it reaches a destination in the gray matter. Now, somatic motor nuclei. On each side of the spinal cord, medial and lateral sequences are somatic motor nuclei that control muscles that position the pectoral girdle, muscles that move the arms, muscles that move the forearms and hands, and then muscles that move the hands and the fingers. Within each of these regions, the motor neuron that controls flexor muscles are grouped separately from those that control extensor muscles. Because the spinal cord is so highly organized, we can predict that the muscles that will be affected by the damage to specific areas of the gray matter. The white matter on each side of the spinal cord are divided into three regions called columns or funiculi. The posterior white columns lies between the posterior gray horns and the posterior median sulcus. The anterior white columns lie between the anterior gray horns and the anterior median fissure. The anterior white columns are interconnected by an anterior white commissure, a region of the axons that cross from one side of the spinal cord to the other. The white matter between the anterior and posterior columns on each side makes the column, or makes up the lateral white column. Now, there are structures referred to as tracts or fasciculus. Each column contains tracts whose axons share functional and structural characteristics. A tract or a fasciculus is a bundle, and a bundle of axons in the central nervous system that are relatively uniform with respect to diameter, myelination, and conduction speed. All axons within the tract relay the same type of information, either sensory or motor, in the same direction. Short tracts carry sensory and motor signals between segments of the spinal cord, and longer tracts connect the spinal cord with the brain. Ascending tracts carry sensory information toward the brain, whereas descending tracts convey motor commands toward the spinal cord. Now, there are some conditions that will disrupt or cause disorder, loss of both muscular or motor movement, and sensory losses. These conditions have been discussed, or at least one of these conditions was discussed in an earlier lecture, multiple sclerosis. Now, this disorder produces muscular paralysis and sensory loss through a process referred to as demyelination. If you recall, myelination is the covering of the nerve fibers by what's referred to as a myelin or protein sheet. The initial symptoms appear to be a result of a myelin degeneration within the white matter of the lateral and posterior columns of the spinal cord or along the tracts within the brain. Now, during subsequent attacks, the effects may be more widespread. Cumulative sensory losses and motor losses can eventually lead to generalized muscular paralysis. There's another condition referred to as the poliovirus. The virus, or the viral disease polio, causes paralysis due to the destruction of somatic motor neurons. Now, this disorder, which also discussed in an earlier chapter, has been eliminated in the Western Hemisphere by aggressive immunization programs. Immunization continues because polio still occurs in other areas of the world. Diseases could be brought into the United States at any time, leading to an epidemic amongst unimmunized children. Paralysis can also result from physical damage to the spinal cord itself due to a severe auto crash or other accidents that can damage neural tissue. The damaged tracts seldom will undergo even partial repair. So once that damage has occurred, usually it's permanent. Extensive damage to the spinal cord at a superior to the fifth cervical vertebrae eliminates sensation and motor control for both the upper and the lower limbs. Again, let me review that area. This is at the level of the fifth cervical vertebrae. If you have extensive damage to the spinal cord at that area, that will cause severe, if not complete, paralysis of the upper and motor limbs. Extensive paralysis produces a condition referred to as quadriplegia. In other words, all four extremities, both the upper extremities and the lower extremities, will be paralyzed. Another condition, paraplegia, is the loss of motor control over the lower limbs and may follow the damage of the tract below the area or in the area of the thoracic spinal cord. Damage to the cord at that level produces loss of motor control only in the lower limbs. Less severe injuries affecting the spinal cord or the cauda equina produce symptoms of sensory loss and motor paralysis and reflect specific nuclei or specific tracts of nerves that are involved. The loss of peripheral sensation, along with the distribution of spinal nerves, may also occur. Now, here's a picture showing you the actual fascial coverings around the individual nerve roots themselves. Here are the nerves, or the structure of the nerve, and as you can see, individual nerve fibers have a covering, bundles of nerves have coverings, and then the entire grouping or bundles of nerves also have a covering as well. These areas are called neuriums. The covering that covers all of the nerve bundles referred to as the epineurum, and the epineurium covering peripheral nerves. Again, each individual bundle of nerves can also have a covering. These bundles of nerves are covered under a covering referred to as the perineurium, and then each individual nerve fiber has a covering as well. This is referred to as the endoneurium. Should be familiar with each of those terms: epineurium, perineurium, and endoneurium. The epineurium is the outermost layer, consists of a dense network of collagen fibers. The fibers of the perineurium, the middle layer, extends inward toward the epineurium. These connective tissue partitions divide the nerve into a series of compartments that contains bundles of axons or fascicles. Delicate connective tissue fibers of the endoneurium, the innermost layer, extend from the perineurium and surround individual axons. Arteries and veins penetrate the epineurium and branch within the perineurium. Capillaries leaving the perineurium branch in the endoneurium and supply axons and Schwann cells of the nerves and the fibroblasts in the connective tissue. Now, if we mention Schwann cells, you know that we're talking about areas in the peripheral nervous system. If the peripheral axons are damaged but not displaced, normal function may, and the key word there is may, eventually return as the cut stump grows across the site of injury away from the cell body along its former path. But the key word there is may. This is not an absolute. Repairs after an entire peripheral nerve have been damaged are generally incomplete, primarily because the problem with the axon alignment and regrowth. Remember, that's a specific tract where a specific nerve fiber has to pass. If there is extensive damage and that tract has also been destroyed or mutilated, it's very difficult for the nerve to return through its original tract. Now here's the distribution of the spinal nerves. And again, I helped you earlier to be able to identify what was referred to as the anterior portion of the cord and the posterior portion of the cord, and you'll see why that makes a big difference. The anterior portion, referred to as the ventral or the motor region, and the dorsal, more of a the dorsal root, more of a sensory apparatus, or it is a sensory. And so you can see the tracks as they leave out. There is a ganglion. Remember, a number of nerves kind of grouped together in one location form this ganglion. So there are dorsal root ganglion, which picks up components from this specific spinal nerve as it passes out. When we look at the anterior portion, or the ventral roots, we see that they extend out. Eventually, this ventral root and this dorsal root are going to join together and form the specific spinal nerve. Now, this specific spinal nerve, as you can see then, will have both sensory fibers and will have both motor fibers. Further division will occur as the nerve passes out and goes through a dorsal ramus. There is also a ventral ramus. And then in these ventral ramus, you can also see that this may go to skeletal muscle. This may also go to smooth muscle as well. Now, this illustration helps you to identify the somatic motor commands and the visceral motor commands by highlighting each of these blocks. The somatic commands to skeletal muscles to the back, as you can see, where these nerve roots are going to separate and go to different aspects of the body. Visceral motor commands, those to smooth muscles of glands in the back. Here, when we see anteriorly, again, smooth muscles and glands of the body wall and limbs, again, extend in all directions through the body. Now, remember two other terms, too, that we talked about earlier. There are postganglionic fibers and preganglionic fibers. It's important to recognize these as well. Remember, the ganglion are where these groupings of nerves are going to come together and then will be redistributed to various areas of the body. Prior to the ganglion, it is considered to be preganglionic fibers. So in the sympathetic ganglion, the preganglionic fibers that lead from the ventral root, they extend here, and then there are postganglionic fibers. You see this both in somatic and in visceral structures. There are postganglionic fibers to smooth muscles and glands. Postganglionic fibers leave after the ganglion. Preganglionic fibers to sympathetic ganglion that will innervate abdominal pelvic visceral also exist as well. So the distribution of motor fibers in the major branches is representative in the thoracic and or the superior lumbar spinal nerve. Although the gray ramus is normally proximal to the white ramus with diaphragmatic view that you've seen earlier, it makes it easy to follow the relationship between the preganglionic and the postganglionic fibers. Now please note that in the previous illustration where you see the distribution between the ganglion. Here's the ganglion. Here are the preganglionic fibers. Here are the postganglionic fibers as it relates to the dorsal root. Here you see preganglionic fibers as it relates to the ventral root. You see the ganglion here and then postganglionic fibers. This is representative of the sympathetic nervous system. Remember, sympathetic nervous system, that fight or flight response, and we'll go into a lot more detail about sympathetic nervous system innervation in later lectures. But what I want you to recognize anatomically right now is what's representative of preganglionic fibers and what's representative of postganglionic fibers. Now, the ventral root of each spinal nerve contains axons of somatic motor and visceral motor neurons. Distally, the first branch from the spinal nerve carries visceral motor fibers to a nearby sympathetic ganglion, part of the sympathetic division of the autonomic nervous system. The autonomic nervous system is divided into two parts, a sympathetic division and a parasympathetic division, and again I'll go into a lot more detail about that in subsequent lectures. Amongst other functions, the sympathetic division is responsible for elevating the metabolic rate and increasing alertness. It is the fight or flight response that we see in our nervous system, increasing heart rate, increasing respiratory rate, dilating the bronchial tubes. That surge of energy we see in crisis situations is coming from the sympathetic division of our nervous system. The term white ramus. Because preganglionic axons are myelinated, this branch has a lighter color, therefore known as the white ramus. Postganglionic fibers that innervate smooth muscle, glands, organs in the thoracic cavity extend directly from the ganglion to their respective effector organs. These axons form a series of sympathetic nerves. The gray ramus, or postganglionic fibers, innervating glands and smooth muscles in the body wall or the limbs, return from the ganglion to rejoin the spinal nerve. These fibers, which are unmyelinated, have a darker color and thus form the gray ramus. The gray ramus is typically proximal to the white ramus, Together, they are known as rami communicants, or communicating branches. The dorsal ramus, each spinal nerve contains somatic motor and visceral motor fibers that innervate the skin and skeletal muscles of the back. The axons in relatively large ventral ramus supply ventrolateral body surface structures of the body wall in the limbs. Now, another structure or sensory structure that it's important to recognize is called dermatomes. The illustration that you see in front of you are the dermatonal patterns related to sensory aspects of the spinal nerves as they come off of the spinal cord, and as you can see, will also innervate cranial structures as well. Now, these are superficial sensory fibers, and I'll go into a little more detail here coming up. Specific regions of the skin surface are monitored by a single pair of spinal nerves called dermatomes. Each pair of spinal nerves services its own dermatonal region. Although the precise boundaries of adjacent dermatomes typically will overlap, typically if there's an area of sensation, there's a spinal nerve, the sensory component of a spinal nerve, that's related to that dermatome. Dermatomes are clinically important because damage or infection of a spinal nerve or a dorsal root ganglion. Remember that the dorsal root is responsible for sensory innervation, so any damage to that nerve or damage to the dorsal root will produce characteristic loss of sensation of skin. Peripheral nerve palsies, peripheral neuropathies, are regional losses in sensory and motor function that results from nerve trauma or compression. You have experienced a mild or temporary palsy in your arm or your leg when you fall asleep and your body weight is actually on the extremity while you're sleeping. If you've leaned in that position or if you slept in that position for a period of time, when you wake up, the affected dermatomes provides clues to the location of injury. In other words, that area, that particular area, circulation has been cut off, there's been specific compression to the nerve, and thus you sense a sensory abnormality. More exact conclusions can be drawn if those losses of motor control on the basis of origin and distribution of the peripheral nerves originating from the nerve plexus. So if you know the dermatonal patterns, you'll know what spinal nerve has been injured, even if it occurs at the point of a dorsal root. Some common forms, before I move on, some common forms of peripheral neuropathies are typically circulatory neuropathies. An example would include a person that has peripheral vascular disease and has blockages in the arteries that supply blood supply, say, to the lower extremity. A person can have a peripheral neuropathy based on a lack of blood supply and nutrients to the nerves where the blood should be flowing to. So if you have a blockage in your femoral artery, which would supply blood to your foot or your lower extremity, you would develop a neuropathy or a nerve disruption in that lower extremity. Another disease that causes peripheral neuropathies extensively is diabetes. Diabetes works a little bit differently. Not only can it block blood vessels, diabetes, the accumulation of sugar or glucose in the bloodstream, has a tendency to gum up or block the circulation going to distal extremities. The legs, the fingertips are good examples. A lack of blood supply to that area over time can develop a neuropathy, a lack of circulation to the area. Diabetes can also, literally the sugar can coat the nerve endings as well. Coating the nerve endings blocks the sensory information that would be returning back to the central nervous system, and the person would begin to lose sensation especially in the peripheral tissue. But extensive diabetes with extensive complications can even affect the visceral sensory fibers, such as nerves that innervate the heart. This is why patients with diabetes can have what we call silent heart attacks or silent MIs, because the sensory component of those nerves have been dampened by the diabetes. These are all forms of neuropathies, peripheral neuropathies. Shingles. Shingles is a condition, a viral infection that can infect the dorsal root ganglion. It causes a painful rash at those distributions, and it corresponds with the affected sensory nerve. Peripheral nerves and nerve plexuses exist throughout the body. Now, we've already talked about how each of the spinal nerves come off the spinal cord. The cervical spinal nerves, the thoracic spinal nerves, the lumbar spinal nerves, and the sacral spinal nerves. These nerves also will meet at certain areas. These areas where these spinal nerves will meet are called plexuses. And typically, these nerves that come off, these spinal nerves that come out, will join together at one point and then will redistribute from the point of the plexus to more peripheral structures. Now, let me give you some examples. Now, the major plexuses of the bodies, and the ones that I'm going to want you to be able to identify, will be the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. Again, nerve plexus, ventral rami, adjacent spinal nerves, blend their fibers, producing a series of compound nerve trunks. Such complex interwoven networks of nerves are called nerve plexus. Because they form from the fusion of ventral rami, the nerves arising from these plexus contain sensory as well as motor fibers. Now, here are the major plexuses: the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. These are from ventral rami, and those are the four major plexuses from those ventral rami. The cervical plexus, and this is its location. Notice that the cervical plexus is made up of a union of C1, C2, C3, C4, C5 spinal nerves. These nerves come off, they meet at a point referred to as a plexus, and then they will redistribute out into various different nerves. One of the major nerves that I want you to remember from the cervical plexus is the phrenic nerve. Please note its location. Cervical plexus consists of ventral rami spinal nerves. The branches of the cervical plexus innervate muscles of the neck and extend into the thoracic cavity, where they control diaphragmatic muscle. That's important to know. Again, cervical plexus innervates the muscles of the neck and extend into the thoracic cavity, where it controls diaphragmatic muscles, meaning the muscles of respiration. The phrenic nerve is the major nerve of the cervical plexus, and it provides the entire nerve supply to the diaphragm. This is the key muscle in the respiratory system. We will discuss the respiratory system later on in the chapter, but if you remember from the muscle system as described in A&P 1, the diaphragm is responsible for 80% of respiration. So it's a major muscle, and the phrenic nerve is responsible for innervating that muscle. Other branches of this nerve plexus are distributed to the skin, the neck, and the superior part of the chest. Table 13.1 in your textbook identifies each of the nerves and the spinal segments which are responsible for making up those nerves. Again, the one from the cervical plexus that's important, and I would expect you to know, is the phrenic nerve. Remember that C3, 4, and 5 keep the diaphragm alive. So C3, C4, C5 are the spinal segments forming the phrenic nerve that innervate the diaphragm. That's important to know. The next plexus is the brachial plexus. The brachial plexus is made up of spinal nerves beginning at C5 and extending to T1. Again, these nerves, these spinal nerves, come off at their main root. They join, they form a plexus, and then are redistributed into more peripheral locations. Three major nerves that come off this area that I need you to know would be the radial nerve, the ulnar nerve, and the median nerve. Now remember that the radial nerve is going to be more of a lateral nerve, thumb side nerve in anatomical position. The ulnar nerve is going to be more of a medial nerve, or little finger side. And again, this is in anatomical position, palms face out in anatomical position. So the nerve that lies more medial is the ulnar nerve. The nerve that lies more lateral is the radial nerve. And then there is a nerve that courses through the center, referred to as the median nerve. would expect you to be able to identify each of those nerves on your laboratory exam. The brachial plexus innervates the pectoral girdle in the upper limb with contributions from the ventral rami of the spinal nerve. Here's an up-close view of the brachial plexus. Again, as you can see, beginning at C5 and extending to T1, you'll see that these spinal nerves join together to make a plexus. There are trunks. These trunks are the union of specific nerves. These trunks will later redistribute nerves that have components from each of these spinal nerves into various nerves. Again, I asked you to be able to identify the median nerve. I also asked you to be able to identify the ulnar nerve, and then I also asked you to be able to identify the radial nerve. Now you have two different pictures where I would expect you to be able to identify these three nerves: median nerve, ulnar nerve, and radial nerve. Table 13.2 describes the spinal segments and the specific nerves that make up each of the nerves that innervate or distribute to specific muscles. I'm not holding you so much to task at knowing the specific spinal segments. I would expect you to be able to identify the ulnar nerve, the median nerve, and the radial nerve in this. These are their functions. Again, all of these nerves have components of a motor function. So you'll see flexor action. You'll also see some extensor action depending on the nerve and where it innervates. So review this table. The brachial plexus, and as I alluded to in the illustration, the nerves form the plexus originate from trunks and or cords. Trunks are large bundles of axon contributed by several spinal nerves. Cords are smaller branches that originate at the trunks. Both trunks and cords are named according to the location relative to the axillary artery, a large artery supplying the upper limb. Hence, we have a superior, middle, and inferior trunks, lateral, medial, and posterior cords. Lateral cord forms the musculocutaneous nerve exclusively and together with the medial cord contribute to the median nerve. The ulnar nerve is the other major nerve of the medial cord. The posterior cord rises to the axillary nerve and the radial nerve. Table 13.2 provides further information about these and other major nerves in the brachial plexus. The lumbar and sacral plexus. The lumbar plexus and the sacral plexus arrive from the lumbar and sacral segments. The nerves arising at these plexuses innervate pelvic girdle and lower limbs. Here you're looking at nerves from components of both the lumbar plexus and the sacral plexus, both an anterior and a posterior view. There will be some specific nerves here that I will expect you to be able to identify. The femoral nerve, the pudendal nerve, and the sciatic nerve are the common nerves that I would be able to expect you to be able to know. You should also be able to identify the sural nerve and the sciatic nerve. Now here are illustrations that show you both the lumbar plexus in an anterior view and the sacral plexus in an anterior view. The lumbar plexus, again, components begin at T12 and extend to L5. Should be able to identify the femoral nerve, which is a part of the lumbar plexus. On the sacral plexus, you notice that the nerves include components from spinal nerves L4 extending down to S5. Major nerves that I would expect you to be able to identify here would include the sciatic nerve and the pudendal nerve. The lumbar plexus contains axons from the ventral ramus of the spinal nerves. The major nerves in this plexus: the genitofemoral nerve, the lateral femoral cutaneous nerve, and the femoral nerve. The sacral plexus contains axons from the ventral ramus of the spinal nerves as well. Two major nerves arise from this plexus include the sciatic nerve and the pudendal nerve. The sciatic nerve passes posterior to the femur, deep to the long head of the biceps femoris muscle, As it approaches the knee, the sciatic nerve divides into two branches, the fibular nerve and the peroneal nerve and the tibial nerve. The sural nerve, also a nerve I told you I wanted you to be able to identify, formed by branches of the fibular nerve, is a sensory nerve innervating the lateral aspect of the foot. Now this is a nerve that's usually removed for nerve grafts. There are other structures referred to as interneurons. The human body has about 10 million sensory neurons, about 1/2 million motor neurons, and 20 billion interneurons. Sensory neurons deliver information to the central nervous system. The motor neurons distribute command to peripheral effectors, such as skeletal muscles. The interneurons interpret, plan, and coordinate incoming and outgoing signals, and this is very important. The billions of interneurons of the central nervous system are organized into much smaller numbers of neuronal pools, functional groups, interconnected neurons. A neuronal pool may be diffused, involving neurons of several regions of the brain, localized neurons restricted to one specific location of the brain or spinal cord. Now, the organization of the neuronal pool is important, and you should know these two terms, divergence and convergence. Divergence, this is a mechanism of spreading stimulation to multiple neurons and neuronal pools in the central nervous system. Convergence, this is a mechanism providing input to a single neuron from multiple sources. These are illustrations demonstrating to you divergence and convergence. Some other terms that we're going to talk about in just a minute, serial processing, parallel processing, and reverberation will also be discussed as well. So please pay attention, please pay particular attention to this illustration. Serial processing, in which neuron pools work sequentially. Parallel processing, in which neuron pools process information simultaneously, and then reverberation is a positive feedback mechanism. Divergence. Divergence is the spread of information from one neuron to several neuron sensors and to one pool and multiple pools. Divergence permits broad distribution of specific input. So again, you have the spread of information from one neuron to several neurons or to a pool of multiple neurons. Divergence permits broad distribution of specific input. Considerable divergence occurs when sensory neurons bring information into the central nervous system from information distributed to neuronal pools throughout the spinal cord and brain. Visual information arriving from the eyes reach your conscious awareness at the same time it is distributed to areas of the brain that control posture, balance, and subconscious level. In convergence, multiple neurons synapse at the same postsynaptic neuron. Several patterns of activity, presynaptic neurons can interfere, therefore have the same effect on the postsynaptic neuron. Through convergence, the same motor neuron can be subject to both conscious and subconscious control. So again, now we have several neurons which synapse on the same postsynaptic neurons. So several patterns of activity in the presynaptic neurons can therefore have the same effect on the postsynaptic neuron. The movement of your diaphragm and your ribs now being controlled in the brain at a subconscious level, but the same motor neurons that can be controlled consciously as well. This is how you can take in a deep breath and hold it. Two neuronal pools are involved here, both synapsing at the same motor neuron, both at a conscious and one at a subconscious level. Information may be relayed in a stepwise fashion from one neuron to another or from one neuronal pool to the next. The pattern is called serial processing and occurs as sensory information is relayed from one part of the brain to another. Pain sensation en route to your conscious awareness makes two stops. One is at a neuronal pool along the pain pathway. Parallel processing occurs when several neurons or neuronal pools process the same information at one time. Divergence must take place before parallel processing can occur. Thanks to parallel processing, many responses can occur simultaneously. When you step on a sharp object, sensory neurons distribute information to a number of neuronal pools, and all of these are stimulated. So as a result of parallel processing, you might be able to withdraw your foot, shift your weight, move your arms, feel the pain, shout ouch, all at the same time. This is because of parallel processing. Now, reverberation is a little bit different. Some neural circuits utilize positive feedback to produce reverberation. In this arrangement, collateral branches of axons somewhere along the sequence extend back toward the source of an impulse and further stimulate the presynaptic neuron. Once reverberation circuit has been activated, it will continue to function until synaptic fatigue or inhibitory stimuli break the cycle. Reverberation can occur within a single neuronal pool, or it may involve a series of interconnected pools. Reverberation is like a positive feedback loop involving neurons. Once the circuit is activated, it continues to stimulate itself. Highly complicated examples of reverberation amongst neuronal pools in the brain may help maintain conscious muscular coordination and normal breathing patterns. There's another phenomenon, or another system, I guess I should say, called the reflex arch. The wiring of a single reflex arch is called a reflex arch. A reflex arch begins at a receptor and ends at a peripheral effector, such as a muscle fiber. So again, it begins at the receptor, ends at a peripheral effector. 5 steps are involved in the neural reflex: arrival of a stimuli and activation of a receptor, the activation of a sensory neuron, information processing, activation of a motor neuron, the response of the peripheral effector. A receptor is either a specialized cell or a dendrite of a sensory neuron. Receptors are sensitive to physical and chemical changes in the body and changes in the external environment as well. When you lean on a tack, sharp object, pain receptors in the palm of your hand, let's say, will be activated. These receptors, or dendrites, or sensory neurons, will respond to that stimuli and cause the accompanying tissue to be damaged. The stimuli of the pain receptor leads to the formation or promulgation of action potentials along the axons of the sensory neuron where the tissue has been damaged. This information reaches the spinal cord by way of the dorsal root. Remember, the dorsal root is responsible for sensory. Now, 2 steps may involve different cells. For example, a reflex is triggered by the loud sound behind you. The receptor cells of the inner ear release neurotransmitters and stimulate sensory neurons. Information processing begins when excitatory neurotransmitter molecules are released by the synaptic knob of the sensory neuron that arrive at postsynaptic membranes in the inner neuron. Neurotransmitters then produce an excitatory postsynaptic potential, which is integrated with other stimuli arriving from inner neurons at that same moment. An inner neuron is not always present in the reflex arch. In the simplest reflex, the sensory neuron innervates a motor neuron directly. In that case, we'll see the motor neuron performs the information processing as summation occurs in the axon hillock. On the other hand, complex reflexes involve several inner neurons, some releasing excitatory neurotransmitters, the excitatory inner neurons, and others inhibitory neurotransmitters, inhibitory interneurons. When we look at the activation of the motor neurons, the axons of the stimulated motor neuron carries the action potential into the periphery, in this example through the ventral root of the spinal nerve. Remember, ventral root is now the motor aspect of this mechanism. The release of neurotransmitters by the motor neuron at the synaptic knob leads to a response by a peripheral effector, in this case a skeletal muscle whose contraction pulls your hand away from the tack. A reflex response generally removes or opposes the original stimuli. In this case, contraction of muscle pulls your hand away from the painful stimuli. This reflex arch, therefore, is an example of negative feedback. By opposing potentially harmful changes in the internal and external environment, reflexes play an important role in homeostatic maintenance. The immediate reflex response is typical not only of the response to a stimuli. In an example given, you might wince, you may say ouch, you may shake your hand. These other responses, which are directed to your brain, involve multiple synapses and take longer to organize and coordinate. Reflexes are classified based upon their development, the site of information processing, the nature of the resulting response, motor response, and the complexity of the neural circuit. These categories are not mutually exclusive. They represent different ways of describing a single reflex. There are innate reflexes that are genetically determined. There are acquired reflexes that are basically learned. There are somatic reflexes that would involve skeletal muscle contraction, visceral reflexes that involve smooth muscle. These are autonomic responses. We don't have conscious control over that. When we look at the complexity of the circuitry involved, it can be monosynaptic, so only one synapse. It can be polysynaptic, or multiple synapses can be involved. These can be cranial reflexes, processing directly from the brain, or it can be spinal reflexes, processing in the spinal cord. The development of reflexes. Now, when we look at innate reflexes, these are a result of connections that form between neurons during development. So such reflexes generally appear in a predictable sequence from the simplest reflex response, withdrawing from pain, to more complex motor patterns such as chewing, suckling, tracking objects with our eyes. Now, innate reflexes, the neural connection responsible for the basic motor pattern of an innate reflex, is genetically predetermined or developmentally it's programmed. Examples include reflexes for removing the hand from a hot stove or blinking your eyes when your eyelashes are touched. Acquired, complex, learned motor patterns are called acquired reflexes. An experienced driver steps on the brake when trouble appears ahead. A professional skier makes a move quickly with his body to adjust his body position while racing. These motor responses are very rapid, automatic. They are learned responses, though, and they're not pre-established. Such reflexes are enhanced by repetition. The person who practices karate knows how to block a punch. Doesn't have to think about it. It's an acquired reflex because the person is trained with this repeatedly over a period of time. These reflexes, again, are enhanced by repetition. Now, innate versus acquired reflexes, the distinction between innate and acquired reflexes is not always absolute. That's why there's some debate. Some people can learn motor patterns more quickly than others. The differences probably have something to do with the genetic basis, but that hasn't been clearly proven. Now, the complexity of these reflexes. You can have a monosynaptic reflex, which involves a sensory neuron and a central motor neuron. This is referred to as circuit 1. In this example, stimulation of a receptor leads to a reflexive contraction of skeletal muscle. You can have a polysynaptic reflex, which involves a sensory neuron or inner neuron and motor neurons. And let me restate that. Polysynaptic reflexes involve sensory neuron, inner neurons, and motor neurons. In this example, stimulation of a receptor leads to a coordinated contraction of two skeletal muscles. This shows you the illustration of what I just described. In a monosynaptic reflex, you see only one motor neuron, one sensory neuron, one effector skeletal muscle. When you look at a polysynaptic reflex, you see more than one motor neuron, two in this case, two sensory neurons receiving information, inner neuron, sensory neuron, receiving the information, then distributing it to more than one muscle. Skeletal muscle 1, skeletal muscle 2. This is an example of circuit 2. The complexity of the circuit: in the simplest reflex arch, a sensory neuron synapses directly on a motor neuron, which serves as a processing center. Such a reflex is monosynaptic reflex. Transmission across chemical synapses always involves a synaptic delay, but with only one synapse, the delay between the stimuli and the response is usually very minimized. There are some clinical reflexes that we can test that have predictable results, and we use these clinically to identify neurological dysfunction. These reflexes, and I would expect you to know them, are called the abdominal reflex, the biceps reflex, the triceps reflex, and the ankle jerk. And I'll talk about each one of these individually. Testing reflexes. When you're testing reflexes, if a clinical stimuli fails to elicit a particular reflex response, there can be some primary reasons for the failure. The person can be consciously suppressing the response. So in some reflexes, we can consciously tell our muscle not to jerk. The doctor taps your knee for the patella reflex, taps your knee. But you can consciously override that reflex by telling yourself, I'm not going to allow my knee to jump. The nerves involved can also be damaged. This can be another reason why you don't see a reflex, and commonly this is why we're testing the reflexes. And there may also be some underlying problems with the central nervous system. 2 and 3 are somewhat related. Clinicians may ask patients to perform a specific action designed to provide reinforcement. Reinforced reflexes are usually too strong to suppress consciously, and if the reflex still fails to appear, then there is a very strong likelihood of nerve or central nervous system damage. More sophisticated tests, such as nerve conduction studies, where we actually can measure the electrical impulses in the nerve, or specific scans can also be ordered. Again, as a review, the reflex usually causes contraction of abdominal muscles called the abdominal reflex just by stroking the reflex hammer across the abdominal wall. The biceps reflex, where you can actually the clinician places his finger over the point of insertion of the biceps tendon. It strikes his finger, which will elicit a flexion of the forearm. There also is the triceps reflex, similarly striking the point of insertion of the triceps tendon just at the point above the elbow or above the olecranon process of the ulnar bone. You strike that tendon, it causes the arm to extend in a jerking motion. And then there's the ankle reflex, where a tapping of the Achilles tendon can elicit plantar flexion of the foot. There's another reflex referred to as the Babinski reflex, and it's important for you to take a minute to understand what is meant by the Babinski reflex, what is a negative Babinski reflex, and what's a positive Babinski reflex. So listen carefully. Plantar reflex, also known as the negative Babinski reflex, is a curling of the toes that we see in healthy adults. In other words, if I take the end of the reflex hammer, which is sharp, it's not sharp in the sense that it's going to cut you like a knife, but it's a sharp edge. If I stroke the center of your foot, the plantar surface of your foot, it will cause you to curl your toes. In other words, your toes will be pointed toward the ground. This is called a negative Babinski reflex. Now, the Babinski sign is a positive Babinski reflex. This occurs in the absence of descending inhibition. It is a normal reflex that we see in infants, but it's a pathological reflex that we see in adults. A positive Babinski sign in adults is abnormal. Now, in children, however, you see this reflex and it would be considered normal. Other descending fibers have inhibitory effects on spinal reflexes. In adults, stroking the foot on the side or the sole produces a curling of the toes. This is called a plantar reflex or negative Babinski reflex, as I alluded to earlier. Now, when you stroke an infant's toe on the side, or when you stroke an infant's foot on the side or right through the midline, it produces a fanning of the toes. Now, this is called a positive Babinski reflex. Normal in children, but when you see that fanning of toes in an adult, you know that this is an abnormal response. Now, the response, even in children, disappears as the descending motor tracts or pathways fully develop. Now, remember, children aren't walking early on. So those descending tracts, which carry motor innervation, have not fully developed in children yet. And we usually won't see that fully developed until about the age of 1.5 or 2 years old, when the child is then upright and begins to walk. At that point, you would start to see the child would develop a negative Babinski reflex. If either of the higher centers of the descending tracts are damaged, the Babinski sign will appear in an adult. Again, this is abnormal. As a result, this reflex is often tested for central nervous system